to introduce Sally Ruane, who is a member of our local camp group. She's also a health policy academic and founder member of the Centre for Health and Public Interest. Sally.
Thank you. Thank you very much for coming this afternoon. I'm going to say a few words about the local situation and some local developments. It's going to be horribly selective. I hope it's not too distorted, but I'm aware that there is a lot more to be said. Louise mentioned that there is something of a funding crisis within the NHS, and the funding settlement for the NHS agreed by the coalition parties was that NHS funding would go up by no more than the rate of general inflation. So there's a real terms freeze in funding every year, year after year after year. But because health service inflation is higher than general inflation, and because we have a growing and an ageing population, and because we have new technological developments and so on, the NHS actually needs, experts say, an extra 4% in real terms each year. And what this means is, as Louise mentioned, that the NHS is having to cut what it does, or to make efficiency savings to the tune of 4% one year, then another 4% the next year, then another 4% the year after. And the funding situation in the NHS has not been so tight for the last 50 years. And this is having an effect on us locally. There has been a calculation locally, and I haven't seen exactly how the figures have been put together, but what we have been told locally is that the expectation is that by 2019, so 5 years from now, we will have a gap in our funding for health and social care to the tune of £400 million. And what this has given rise to is something called a 5-year plan. At the moment, all of the key parties of health and social care, the NHS and social care across the city and the counties have come together, and they are involved in a process of discussion and negotiation to arrive at some redesign of the way in which healthcare is being delivered and social care is being delivered. And they're looking particularly at cancer, dementia, cardiovascular disease, respiratory disease, and mental illness. And this is being rushed through, I think it would be fair to say. They've been given a few months to do it, and I understand that they have to have this agreed by the end of this month. Now, a lot of this is going to involve, as far as I can tell, is going to involve moving healthcare as much as possible out of hospital settings and into general practice and into community settings. And that is very much the way in which the government wants things to go, and that is the way in which I think things are moving locally. Now, of course, there may be all sorts of ways in which it's good to take care out of hospitals, providing we don't financially destabilise the hospitals and destabilise everything else they're doing. That could be beneficial, but there are risks associated with this, and I think the rush with which this is being done is, for me, one of the risks. And as an academic, I'm concerned to see what the evidence base for the proposals is going to be, because there is not particularly strong evidence for moving quite a lot of services into the community, and there's not particularly strong evidence that you can actually save a lot of money by moving services into the community. So I'm intrigued to see what the proposals will be and what their evidence base will be. As a campaigner, I also have a concern that once you move services out of a district general hospital into the community, they then become easier to package up and to contract out. Can you see what I'm saying? It's much easier to do that with services. It's also much harder to know what's going on when things are in the community. It's harder to monitor things in the community, and it's harder to know if something has just disappeared in the community or if the quality of care has declined. So I think there are a number of risks. I don't want to scaremonger about think there are a number of risks. I think one of the things that I would want to be keeping an eye on is if general practitioners are going to be expected to do much more work because care is being moved out of hospitals and into community settings. One of the things is, are there enough GPs to go around? And Louise has already referred to the national shortage of GPs, and my understanding is that we also have a local shortfall of GPs. And one of the questions I would be asking now is, what is the current situation with patients being able to see their GPs promptly? So, what proportion of patients find they cannot see their GPs promptly at the moment? I don't know even whether we're collecting data on that. I certainly don't know what the answer to that question is. But if we're moving a whole load of extra work onto GPs, is there going to be a risk of patients not being able to access the GP that they need to be able to see for their particular condition? So for me, one of the things I would be keeping an eye on is, as a kind of barometer, if you like, is there a difficulty in people accessing their GPs? It's also the case that if you're moving care away from specialists and hospitals towards more general practitioners, even if a particular GP in a particular practice trains up and does extra training around, for example, dementia, does that compensate for the lack of access that you then have to the specialist in the hospital? Maybe it does. Maybe in most cases it's good enough to get an extra trained GP in that condition. But for me, it's just, again, it's one of those risks that I would want to see being monitored. I think what I would be looking for as a result of this is some kind of risk register. What I'm waiting for, when the proposals come out, I want to see what the evidence base is. I've seen on the website, there is a website, it's called Better Care Together, I think, and they have updated it, and you can go on and look at their a very long slide show on that. And they put up there a case for change, but really there is no evidence which is supplying with that. So one of the things I'm looking for is evidence, and the other thing that I'm expecting to see is a risk assessment when that group delivers their proposals. I want some kind of risk register to see what risks they have identified as associated with this new model of delivering healthcare and how they plan to address those risks. Because one of the concerns about this kind of redesign of services is that if you have a redesign of services which is driven by financial pressures rather than by quality concerns, you might end up with poorer services because they're cheaper services. Now, I don't have the slightest doubt that our local NHS and social care people will be doing their level best to make these the best services that they can possibly make. But nonetheless, when something is financially driven, there is always that danger. And one of the interesting features of this 5-year plan is the involvement of a consultancy firm in it. And it is called Ernst & Young. I don't know if you've heard of Ernst & Young. They're one of the big 4 global accountancy firms in the world. Their involvement in the local discussions is not being paid for by us locally, I understand. It's being paid for by NHS England and Monitor and others. And I gather they may be being paid up to £800,000 for being involved in these local discussions. I'm not entirely sure what they will be doing, but they will be giving advice, I'm sure, and helping perhaps with some of the modelling. But one of the things that strikes me about this is that Ernst & Young will now have very intimate knowledge about the way in which our health and social care services run, about what those services are, about what the pressure points are in the system, and they will also have very intimate knowledge about our local health and social care finances. And I would be quite intrigued to see, and I think this might be something for our group to do, is to maybe get a Freedom of Information request to find out what the nature of the contract with Ernst & Young is, because I would like to know whether they're going to be able to share the information that they gain here in Leicester, Leicestershire and Rutland with other clients of theirs, which may be private healthcare companies or social care companies. Do you know what I'm saying? Because we know that McKinsey have done that. They have shared knowledge with other clients. So something to watch there. There have been pressure points in the local health system. The financial pressure has already been expressed through the deficit that the hospitals have. There is now a hospital deficit of about £40 million, and it's looking tricky to shift that. And a lot of that is not to do with mismanagement. There might or might not be with mismanagement, I don't know. But the majority of that is not to do with those sorts of local factors. It's to do with a policy of taking services out of hospitals, which means they can't earn their money. And it's to do with the technical details of how they are being paid for the services that they give. And there are a number of policies at the moment which are serving to destabilise financially our hospitals. And Louise mentioned accident and emergency, and that this was a problem across the country, and sure enough, it has been a tremendous problem here with our hospital in Leicester. And apparently we now have the biggest A&E, I think, in terms of attendances in the country. I hadn't realised that. Many more people are attending than actually the A&E unit was designed to handle. And I think it is months now since the hospital was, I hope I'm not being unfair here, but I think it is months since the hospital was able to meet its 4-hour waiting target in A&E. They've had many more people turning up for A&E. Is that a sign that GPs aren't open already in the community? I don't know. And they are having difficulty discharging patients back into the community because the care packages aren't always available in the community. So, and this there, and if you don't discharge people, you don't have any beds to put new admissions into. So that is a pressure point. We also have, I would say, a shortage of beds in the mental health care sector. Bradford unit has been in the news sometimes for very unhappy reasons in the recent past, and everything points to me towards a shortage of beds within that unit. And the Mercury reported, some excellent reporting by the Mercury. The Mercury reported earlier this year that in the year up to March 2014, over £4 million had been spent on paying for mental health care for patients outside the area because we don't have beds inside the area. So it is, I think that is something for us to concern ourselves about. And I gather that there are plans, I don't know if the decision has been made, I might be behind the news here, but I know there are plans to close the mother and baby unit down as well at Bradford, so that mothers with mental health difficulties and their babies will have to go either to Washington or Derby, which is really very, very unfortunate when you consider how important it is to have your family and networks around you when you have a baby. So, the last thing I want to talk about is privatisation and some of the local picture here. And I think it is important to say that the vast bulk of the NHS budget locally is being spent on public providers. That is the way it is at the moment. The vast bulk of the money is being spent on public providers. But there are some private contracts. We know that some of the planned care is being done privately. We know that physiotherapy is likely to be provided by multiple providers. We know that residential care, there's a lot of private provision residential care and so on. And there are various other relatively small contracts with private providers. However, my expectation and fear is that with the 5-year plan and moving more services into the community, that what we will see over time, particularly if the financial pressure means they're looking for cheap providers, that we will actually see some public provision replaced by private provision. The two contracts that we have been monitoring quite closely ourselves are the Interserve contract, which is for catering, cleaning, maintenance and security in the hospitals as well as other NHS buildings, and the Arriva Transport Solutions, an interesting name, the Arriva Arriva Transport Solutions contract for the non-emergency patient transport. So that's the ambulances that go around, but not taking people with flashing blue lights and emergencies, but in taking people from home to the hospital for treatment or for appointments and so on. Now, Interserve, there's been quite a lot of bad publicity for Interserve. They certainly at one point they were failing to meet their standards of cleaning and were below the national average for their cleaning. There was a bit of a scandal a few months ago where over several days meals were not produced on time for hospital patients, but instead were turning up several hours late, not minutes late, several hours late. And this was very compromising for patients receiving medication, because medication is often associated with before, during or after a meal. They have revamped the restaurants and there is more choice of food, but again the price of food has gone up. And they have alienated their staff, not only by changing working conditions, increasing working hours, changing shift systems and so on, but also by failing to pay their staff. Apparently on 2 consecutive months, Interserve did not pay their staff properly, to the point where those staff were considering strike action. It came very, very close. So I think Interserve, that's something that is yet to prove itself as a good provider. Arriva provide non-emergency transport. This is, I think, a £26 million contract running over several years. Again, these are both quite big contracts. Again, they've taken all the staff, as Interserve have, all the staff have to transfer out of the NHS or whoever they were with to the private provider. Huge amount of problems with the Arriva contract. Tremendous number of problems. Patients waiting hours to be picked up, to be taken to the hospital. Patients having to cancel their operations. Some cases in the newspaper, one patient, a gentleman of 90, nearly 90, forced to cancel his heart operation because he couldn't get to the hospital on time. And at one point, at least, Arriva were found to have been meeting none of their time targets at all. And they have faced multiple penalties.